Welcome to The Virtual Shift, a show looking at the seismic changes happening in healthcare with virtual care at the epicenter. Join me and my guests as we look at key cultural and policy shifts impacting how providers, payers, and patients connect, as well as how care is being reimagined both for today and the future. Hello, and thanks for tuning in today. I'm your host, Tom Foley. You can learn more about this show by visiting the program on healthcarenowradio.com, and be sure to follow me on LinkedIn, Twitter at FoleyTom, and the hashtag The Virtual Shift. We have a great guest on today, Don Antonucci. He is the president and CEO of Providence Health Plan. Don, welcome to the program.
Thank you for having me, Tom. I really appreciate it.
Awesome. Don, the reason why I have you on the program, you are an outspoken person on, at least on LinkedIn as I see you, on very creative thinking relative to how do we move to value. And you're encouraging the market to move in that direction. So I want to get into that conversation during this program. I'm sure my listeners will be very appreciative of this dialogue. So first, tell us about Providence Health Plan and yourself.
Thanks, Tom. Providence Health Plan is a health plan that's been around for about 39 years, and it's been part of Providence, which is a 165-year-old plus primarily delivery system. And, it's been primarily based in Oregon. And so we're now in the process of expanding into some of the other states, especially aligned with where Providence, the delivery system, is. We're about 650,000 members, $2.3 billion in revenue, and we serve every single line of business for the health plan. I've been here 2 years, and I'll just share part of what really drew me to Providence is one, working for a mission-driven nonprofit organization like Providence is important. We have a promise that we share with Providence to know, care for, ease the way of our members, our patients, our providers. So that was really important. But from just an opportunity perspective, I know we're going to get into this, really being able to integrate in a different way with doctors, with delivery systems in a way that's good for members and patients was a huge draw for me. And so being here now coming up on 2 years, there's a lot of opportunity ahead. We've done some good things, but more to come.
Awesome. So you often do talk about this move from fee for service to value. As a matter of fact, on a post you have on LinkedIn today, and I do encourage our listeners to follow you, you say, I'm optimistic about how models like virtual-based care and whole person care, very interesting, as well as innovative technology can help solve issues such as healthcare workers, burnout, and the cost of care. Can you talk a little bit more about what you're thinking there?
Yeah. And, I do think, we may have a terminology problem inside of healthcare sometimes because I'll use terms.
I don't buy that. But go ahead.
I mean, and, you use the term value-based care. I use that quite a bit. And you hear a lot of dialogue. Is it the right term or is it not? And whole person care, same thing. And I think the key is for us in the industry, but for all is to explain these things and what we mean, like we would to a mother, brother, father, sister who's maybe not in the industry. So, what I mean by that is there's first of all, fee for service care, which has been the primary way of healthcare here, is really paying on volume. So you're paying, doctors are getting paid and providers are getting paid on every service that they do. So the incentive, whether it's direct or indirect, is to, hey, there's a nail. I've got a hammer. Let's go. This is what I've got to do. Let's provide that service. Whereas value-based care is less about volume and it's more about value. And how do you go from volume to value? And that is really much more about when we say things like whole person care, having the time to really understand, Tom, what's your health history? What are you focused on? What are you concerned about? And then providing the most affordable quality solutions that are going to make sense for you or your family. That's what the promise is of value-based care. The other thing I'd say too, technology is really important to this whole equation as well. We have to have information that connects with there's too much disjointed information today. So how do we have that comprehensive view of health records, et cetera? But I'll also, and maybe we get into this a little bit too, I'm also saying that value-based care is not a silver bullet solution either. It is, I believe, directionally the right place to go, but there's also some connotation that comes with value-based care when people are asked about it. There was recently a study done that even shared, when people think of value-based care, their first reaction without a definition, not being in the industry, is that cheap care? Am I going to get what I need when I need it? And so I think we've got to start to talk about very specific components of what value-based care is meant to be, and also realize that it's not a silver bullet solution. And then maybe even start to change some of the terminology. I mean, there's been, talk about, is it quality first care? Is it patient first care? But something that's a bit more easy for folks to digest with examples.
Yeah, I often use that terminology of volume to value in a lot of my discussions, and that's really the key. I think that the challenge is, and I'd love your opinion, is that I'm not sure providers know how to get to value. They see it, they want to do it, but they're in this daily hamster wheel, of running faster and seeing more patients and spending less time, and not having the skills. That's not the right word. Not having the time to ultimately put a strategy together that moves them towards a value-based care. Because I think that sometimes there's things that you could do today that doesn't necessarily mean you have to take on a risk-oriented contract, right? I talk a lot on my program about remote patient monitoring, chronic care management, 2 value-based care programs. But if you implement them, you can actually see how you can get the value.
Yeah.
Right. And to me, that's I think the challenge here is demonstrating the pathway to value.
That's right.
And any additional thoughts there?
Well, I think you've nailed it. And I know we've talked about this in the industry quite a bit. And the good news is the dialogue is picking more and more up on what the challenges are to moving over to value-based care, or more towards value-based care. It really is. You've got your foot in one kayak and another foot in another kayak. And how do you make that shift? And I think there is a part of what we need to start to do is start to recognize what are the steps that need to be taken. What are the challenges that are going to come up in moving to those models? Because you can't, in many cases, you can't flip that switch overnight and say, hey, I'm going to take this delivery system or this doctor's office and just totally go over to value-based care, because it's just not set up that way. So I think the first step is just kind of, defining reality, recognizing it, and then starting to take those strategic steps. You mentioned, taking on risk. That's part of it. To take on risk, if you're a provider and you haven't done that before, you're really going to need a whole different level of population health information about who am I managing, what are their conditions, have they had this, this type of preventive care, and you're also going to have the time and capacity and tools to be able to take care of a population differently. One of the examples I've given is I had a couple months ago my doctor visit with my primary care physician, and much of their model in that office is still fee for service. So I just asked, once he understood where I worked and what I did, what's your daily, patient volume? He sees anywhere from 18 to 20 patients a day. And so it's quite a bit. And he also talked about it's really hard, even on his day off. You've got to enter information and do some of the administrative pieces. And part of it, they have to see that many patients to make that business work. One of the good news items, though, and this kind of gets into, I think, one of those components of value-based care, was he also talked about in the first, now for 2 months that he's been working with it, in the first 10 minutes of sitting down with a patient, he's getting so much relief because now natural language processing is helping him just have a dialogue, and the MyChart record is populated with key information that otherwise he would have had to do. And I asked him how much time that saved him. He's like, it's a game changer. It's like an hour a day. So it's an hour back for his evening. It's an hour back for him to do something else. Maybe, take a little time, get some exercise, go for a walk, or get some sleep. And so when I think about things like provider burnout, how do you, I talked about our promise. How do you care for and ease the way of our members, our patients? Well, part of that is also with value-based care. How do we do that for our own providers and make sure that they're able to operate in a way that makes sense for them and makes sense, therefore, for the patient?
No, I'm with you. And, and under volume, we're stuck in this model of the average Medicare patient with 5 chronic conditions sees 9 different doctors. They're only in front of their doctor 15 hours in a given year. The gap in care, in my opinion, is what happens in the other 8,745 hours. I have 9, and so in volume, the only, I know doctors think differently, but I'm going to blow it out of proportion. And the only thing the doctor is thinking about is when I see that patient in the next 3 months per my request to have another scheduled appointment, or another 6 months, right? There's a lot that happens there. So patient engagement is critical. And so to get to value, and you said it earlier, you need a lot of data.
Yeah.
But I'm a doctor. I don't have time to look at this data on a day-to-day basis, right? I still have a lot of patients that I want to provide value to, right?
Yeah.
But I can't do it. But so you need an army, right, to do that. But so the question is that what do you think we could do differently in the short term relative to how we do a better job, because the EHR is not the end all be all relative to where the data is. How can we do a better job in patient engagement in that time that they're away from the office? That's really where wellness is achieved.
Yeah.
Care is delivered in the office. Wellness is achieved at home.
Yeah.
Right. And how do we correlate the home activity with the office activity and push that patient into, not push, but you understand what I'm saying, move that patient into this value mindset?
Yeah, I think part of this is actually, and I'd love your reaction to this, is rolling up our sleeves and really getting under the hood of what does that provider's day look like in their experience? What's the patient experience coming out of that? And I'm talking about everything, even the small stuff, like when you go into the doctor's office and you're filling out a form and it's asking you, do you have the food that you need? How many drinks per week do you have of alcohol? When it's those things, and then how do they get populated and then surfaced in a way to that provider to make their job easier? What's the support staff around that office? I really think it's getting under the hood and doing that. And I also, and I think it's being real about that. And I kind of think about some of these technology companies, the big tech that I know has really made some advances and has tried to get into healthcare. And it's more complicated, say, than retail and banking and other things. There's a lot of complications because of how healthcare's set up, and I think there's a realization of that. But I also think there's some great tools and technology that actually has been around for some time and has only gotten better that makes that easier to be able to surface and approach. There's ways to do that. But I think there's also the reality of how many different payers or how many different systems and point solutions is that provider experiencing? How many are being thrown at that member or that patient? And so I think we've got to have a realistic look. And we use terms like what's the patient journey or the member journey? What's the provider journey, through a day? I think that's where it's going to make a real difference for us. And we have to get under that hood. And then I started thinking about this concept too, about like, if you think about Amazon and how they use, Prime and the app, and again, totally different context. But, I think that consumer centric mindset, I don't know if they were thinking about, well, if I provide this app and if we use this technology over here, we're going to get to consumer centric purchasing. I think what's the easiest, best way, most convenient, affordable choice that makes it easier for somebody to go ahead and do that. I think we got to apply that in healthcare. It's harder, but I think we got to do that.
I am with you 100%. And I'm translating all that into experience. And experience from the consumer's perspective. If I have 5 different doctors, 9 different doctors in my earlier example, I'm not going to 9 different patient portals. Sorry. And I'm not going to have 9 different telehealth apps on my phone. Sorry. And those 9 different doctors need a way to share information so that, if you're the primary and I have a team of specialists, healthcare is a team sport. It's not an individual sport. So, and from a payer's perspective, a health plan perspective, we need to know, to your point, about the whole person, not just about the encounter, not just about, hopefully we can start recording vitals and they can tell us a little bit more about their home setting. and the social determinants of health, right? And understanding, did they take their meds today or not take their meds? Did they eat, diet, exercise, all that stuff? That's the whole person. But that's why I was going earlier with the question on the data, because I think if we were now, the ONC is, the CMS is doing some stuff on the QHINs, and that's all good stuff, but I don't think it's enough, because we're still trying to share data from an EHR perspective, not data from a whole person perspective. And I think that is ultimately going to be the turning point, the tipping point of how we do a better job in delivering value to a patient.
That's
Thoughts?
right. Yeah, I love where you're going with this. I mean, if you even take, we've got some of the right things happening in different parts of healthcare. So if you take Medicare Advantage as an example of really value-based care, and the Centers for Medicare and Medicaid Services has really done a lot to promote those types of models. But if you take Medicare Advantage, and then you take what I kind of mentioned about understanding the whole person and what you're talking about, or data intake, things with Medicare Advantage that makes it interesting is you've got things like dental benefits that's included with it. Sometimes you got transportation benefits, you've got food benefits. And when you think about, if you know somebody is struggling with food insecurity, or hey, did you have trouble getting to the doctor's office, or do you need to have a different type of appointment time because you need to schedule that transportation, if we can connect those dots for the whole person, there's benefits that link directly to that. And I think today some of those exist. I don't know that they're utilized in the way that they could be, but I think starting to connect those things together for folks is going to be the important, shift.
Yeah, and I had a gentleman on an earlier discussion on the program, Michael Grace. He focuses a lot on urban USA, and he tells us about a patient really does want to change. However, and you talk about access and value, and that person can only go to the neighborhood deli, and the neighborhood deli only has 66 flavors of beer, potato chips and pretzels, but they don't have apples and oranges, tomatoes and lettuce, and healthy foods. So to your point about access to transportation, access to a different dietary experience than what they could get by walking down to the corner deli. To me, that is, and again, that all happens in the 8,745 hours they're not in front of the doctor, right? So to me, if we're going to change healthcare, if we're going to move to value, and everybody's going to win in that model as a community, because it is a community of care, change the way in which we think about that structure. It's a hard spin. I'm not discounting the issue, but I think that's really where a lot of the change has to come. Your thoughts on that?
Yeah, I think you're hitting it. I mean, the other thing we haven't talked about yet is the components of like health equity. So, health equity is really important. Value-based care can provide more equitable care. Are you capturing race, ethnicity, language? We've taken some small steps too in our provider directory. We make sure that people can look up and see those components, race, ethnicity, language of their own provider, because we know that therefore there's more likely to be that better connection. How do we think about community-based organizations? So we were talking about food insecurity. So it's great if you got a food benefit, but as a health plan, there's certain things that we can do. But we also have started to think about, all right, with our community partners that are out there, let's start to think about who we support in what ways. So we've got a relationship with the Oregon Food Bank, where
Awesome.
we do volunteer work, we provide funds and all of that. But I think it's bringing those things together and connecting those parts that make people aware of the resources that are around them. They're maybe based in the community that are outside of the traditional medical payer landscape, and starting to connect that and bring that in. And that's also exciting, because I'm starting to read and see and hear more and more stories about that. And I think as the industry and as we all learn about what works or what works better, I think we're going to continue just to see that model take more and more hold. And that's also being pointed out, even where private equities investing in value-based care. And I think McKinsey came out with some information that talked about the likely growth year over year of value-based care. Because if it's not that direction, where are we going to go? Fee for service, if we stay there, that's just not affordable going forward. That's just not going to work. And so that this is a shift that we need to make. And like I said, we also have to be aware that it's not everything. There's other things we've got to do, and there's no silver bullet perfect solution there, but it sure does seem like it's the best direction to head in.
I would agree. If we stay in the fee for service model, we'll never get to the whole person.
That's right.
Never. Right. And that's really the key. If we're going to transition the model to be having the consumer be more empowered and be able to make decisions, we have to get out of that fee for service. And I am, and so everybody in the market is frustrated, right? In the context of there's really low penetration in this model. But I still come back to my earlier point. I think that there's a lot of interest in doing it. I just think that they need to have a pathway and some experiences of their own that says, hey, wow, I'm doing this and I'm realizing that my patients are more compliant with their medication. And I realize that they're staying out of the emergency room, and I realize they're not being admitted as much, right?
Yes.
And they're starting to die. So just a little step can create a whole new vision, because you can see a whole new world in that sphere, right? So I think that there's the right tool sets in place. We just need to get the constituents, the stakeholders, to help implement that. And I think that the best person or the best entities to actually embrace this is not the providers themselves. It's actually the payer.
Yeah.
And I'll use the example. I'm from New Jersey, Central Jersey. I can go to New York to get some very good health care. I can go to Philadelphia to get some very good health care. I can go local in Princeton to get a very good health care. I got 3 different geographies in 3 different states. And the only person that really knows me is my payer.
Yeah.
And so even the idea of sharing that data, it's a tough play. So the payer, to me, is the new champion.
Yeah.
Don't leave it to the provider, because what we want to do is actually share whatever information you collect. You want to be the distributor of the information so that your provider network understands that whole person wherever that patient enters your network. Thoughts?
That's right. And, I will say this because I've worked primarily on the payer side only for the most of my career for 30 years. We have a unique advantage. The term comes out a lot, payvider. And again, there's no silver bullet solution today in healthcare, but boy, is there an advantage there to really better connect the dots. I mean, even as simple things, if healthcare is local. So what's happening in Oregon is very different than what's happening in New Jersey, as an example. And so having that knowledge on the ground of what's happening, where are there access issues, where's there affordability issues, a focus on value-based care should be a model that just continues to grow and make sense. I also think your point is right on. Payers, I believe, can be the sort of navigator, have a lot of the information they need, that connected information from the provider side as well. I think that the challenge there is going to be, you got to make those direct connections and partnerships. I can tell you that the 2 years I've been now at Providence Health Plan, being part of Providence, I not only have a deeper respect and understanding of what doctors are going through and delivery systems inside of Providence, but even our partners that are outside of Providence on the delivery system side, a much different understanding. So that's, I think, a very important advantage that I know that we're trying to take advantage of. And by advantage, I mean focused on that promise to deliver for our members, our patients, our providers.
Yeah. And I'll just add to that, the payer, not try to influence each individual provider, because that's a big burn. But payers working with IPAs, payers working with ACOs, payers working with MCOs. That's because you have mass, right? The average IPA has 475 providers, right? So you get them all on the program, and you hit a community all at one time, if you will. And that's the influence, as opposed to going to each individual primary care provider. You're not going to be able to do that, with all due respect. It's just too big of a burn, and it's going to take too long of a time to create that influence where the experience across the community is felt. So So a payer can offer a platform and say, hey, if you want to do telehealth, here it is. You want to do all these value-based care, use us. Now that provider might use different payers for sure. We all know that problem. But Providence or any other payer could help collaborate and be that champion across the community more so than anything else. Any thoughts on that before I go to our close?
No, I think you hit it. I think there's just a huge opportunity here, and I also think, kind of back to where we started, I think we've really got to define very specifically, get under the hood of what we mean by value-based care, even just if they're just different components of it, because there's also too much high-level dialogue in the industry about like, well, value-based care is not going to work, or that is the solution. And I think we've just got to kind of step through it. And like I said, I'm very optimistic because it seems like in the past couple years, not only has the dialogue picked up, but there's more recognition of this is where things need to go.
If you were asking for regulatory change to influence your movement, what would you ask for?
I would say there's some of this happening today. So even just bodies like the Centers for Medicare and Medicaid Services, they've come out with bold statements of, hey, we want to see all Medicare Advantage, all Medicare over to value-based care by 2030. So I think whether it's policy or whether it's just large public entities and even large commercial employers saying, hey, truly for us, quality, affordability, accessibility is important. And then focusing, I think, also on what are those standardized measures that we're all really going to agree to. So how are we really defining quality? There's probably too much that we are defining. So what's that core set that we know that is heading in the right direction for us? And I also think you can't talk about quality without also talking about the affordability and accessibility side. We sometimes forget about the patient experience measurements and pieces. So I would just say more of that. We're seeing these models. I mean, Medicare Advantage takes advantage of survey data, takes advantage of quality data, and just applying that more broadly into other segments of the population.
Very interesting. And maybe we can have another show just on the cost side of the equation, because I'm a believer that the copay is half the inhibitor to access the care. But Don Antonucci, President and CEO of Providence Health Plan, I truly appreciate the conversation. Very enlightening, I know, to me, and I'm sure to my listeners. So thank you very much for coming on the program, and hopefully we'll see each other soon.
Thank you for having me, Tom.
That's today's shift. I appreciate the audience taking the time to tune in. If you missed part of today's episode, you can tune back in at the healthcarenowradio.com at the same time, 11 a.m. or 7 p.m. Eastern throughout the week. And be sure to check out the program page at thevirtualshift.co. As well, remember to follow me on LinkedIn, Twitter at FoleyTom, and follow the show's hashtag, The Virtual Shift. I'm Tom Foley. Until the next shift.